All right, guys, we're back. IV and meds, and now we're going to talk about some advanced stuff with starting IVs, okay? I kind of want to make sure that you pay to this. I know this was kind of a bit of a long chapter, but it is the bread and butter. It really is. And so we need to make sure that we have this down and good and ready to go. The external jugular. I said it in the last video. I'm going to really say it now. Guys, I love the external jugular, man. I intubate. I turn their neck to the side, stick the external jugular, boom, have a nice day, okay? Now, a lot of places, they lose their mind about the external jugular because, again, it is a little bit more prone to infection in site, but again, when we're accessing this, there's usually a solid need in order to do this. You usually put the patient supine when we do this, or a little bit of the Trendelenburg position just to get some fluid out of the legs and that back up. Starts to back up this that helps engorge it so that we can do it. We usually turn the head to the side and we clean the site with antiseptic solution. So again, turn it to the side. Look at that EJ. Good Lord. I mean, that thing. Now, the biggest problem with starting EJs, guys, is you got this in the way. I think that there's ways around it. Number one, you don't go at this with a 22 gauge needle, gang. This one, at least an 18, okay? You just have to. That's going to take, look how muscular that is. You're going to have to use a bigger needle. Me, I kind of like a 14, but that's me. And I would use a short 14. I would not use a 2-inch long because then you're going to run into problems with the catheter and the needle setup actually running into the ear. It actually, you want to do this. It's a little bit harder if they've got to keep the C-spine. Hopefully you won't have to do that. But usually I like to turn the neck all the way to the side when I'm doing that. They access it. They're actually using the iodine swab. Thank you to whoever did this picture, because again, I want to make sure it's good and clean when I do this. Now, this person actually occludes it using the finger. We do not use a constricting band across somebody's neck. I'm going to say that again so everybody understands. We don't use a tourniquet across their neck. Okay. But we just simply on one side, just above the clavicle, stick your finger down there. Now here's the problem. If you're starting an IV, what happens if you hit the bump in the road? And you just got to remember to keep your finger, again, away. Now, notice that they're actually using a nice, big, huge needle, which is what you should be using. Go in at about 10 to 30 degree angle. Insert, again, and by the way, this one's cool because you can actually suture it down. If I'm in the critical care truck, I would probably suture it in so that they wouldn't go nowhere. But the thing is, you got to really make sure that you tape this down, right? And by the way, you want to make sure that you're in there. Your flash, go a little bit slower because remember, you might not get the flash that you would when you had a tourniqueted vein. But if you keep and hold down the pressure way down on this guy right here, then it should fill up pretty easily, okay? And he's actually drawing it through the needle. Usually I just do it. Pretty much nowadays, they don't have the needles where you can do that. So again, 10 to 30 degree angles, and then again, spike your solutions. And again, just make sure that you put when we do this in the lab, guys, going back to here, we usually put a set on here, and then we tape it at that point. Make sure your tegaderm is over this. Again, you really want to secure this in because probably it was the only IV chance that you're going to get. You really don't want it to go anywhere. You pull out an external jugular, it's like a day without sunshine. You just don't want to do it. All right. So IV access with a measured volume set, or Buretrol set is the name. You're gonna have, and the reason we call it a Buretrol set is because the burette, that would be this chamber right here. This is usually used in pediatrics when we don't, or really fluid constricted patients where we want to make darn sure that we don't want to give too much. Or if I'm mixing a medicine, I can use this to help mix a medicine. Let's say that I want to put it in 100 milliliters and I want to run it in over a certain period of time. This allows us to do that, okay? So again, we usually fill this, we will fill this chamber with whatever we need, and we usually make sure that that clamp is reclamped so that we don't get too much fluid into the patient. Biggest thing when you use this, though, guys, you got to absolutely make sure that you make that this doesn't empty out, okay? Because then you get air in the line, then you have to disconnect it, and then make sure that the air is bled out through it. All right, so again, we're going to fill the chamber, and I will tell you that they do come in different sizes, but usually it's a 10-drop set that they'll use. It kind of depends on the manufacturer here. Make sure that you find out how many drops per milliliter is this set is for. If it's got a really thin rod in there, it's probably a 60 drop. If it's got the bigger drop, and we'll take a look at that in the lab when you guys are practicing. If it's got the bigger drop, then it's, again, a macro drip set. Again, make sure when you're getting blood tubing, remember that you're going to spike the port. You squeeze the drip chamber till it's about a third full. And again, this allows, and sometimes they will have systems that actually do this with the blood tubing, but you usually have a bag of normal saline with it, and this is that Y connector that they were talking about. So we usually fill that about 1/3, and then this is, again, the filtering process right through there, okay? And again, we attach this, and then we just, again, let them flow. And again, normally, if you're giving blood, guys, we probably try to get it in as fast as we can. There might be some times where we would limit the flow, but pretty much we don't. Especially when you're usually given a blood product, it's usually because of a trauma. So things that are going to mess up your IV flowing, okay? And this is one that I literally have some great videos of people failing scenarios. Restarting an IV when all they had to do was pop the constricting band, okay? So take the constricting band off. If it's not flowing, that should be the first thing that you always check. If you got edema at the puncture site, yes, even though you're in the right spot, what happens if it starts leaking out around it? You're going to have to change the IV, okay? The cannula is against the valve, the wall or the valve. Yes, it can happen. I've usually found, though, that it's a very rare thing. It very rarely happens. Make sure that your IV bag is kind of up. It's got to be above the patient. The higher it is, the better it's going to flow, the faster it's going to flow. If you let it fall down, guess what? You're going to get a backflow, and backflows are bad, okay? Completely make sure that the filter is changed, and then the catheter patency. Again, yes, they do block off. They can occlude. They can actually form clots at the end of the catheter. Again, it's a foreign object to the body, so unless there's something flowing through it, usually it can clot off, okay? Takes a little bit of time sometimes, but if you've got somebody that's got like factor 7 problems, something of that nature, where they have a clotting disease, it can happen. Again, some of the complications, you can get pain in the area. You can get a local infection. You can actually get the vein infected. It'll actually start to feel warm, which is that pyrogenic reaction. That's when it actually starts flowing through there. Yes, you can get allergic reactions from an IV. It's very rare, but it does happen. Catheter shear. We talked about this when we were practicing the initial insertions. Guys, number one, catheter shear. I've had a couple actually where they would break off. Make sure that when you're pulling the IV, that the catheter is intact. And I would document that when I was removing an IV. The IV was discontinued with catheter intact. Because that way it shows that, hey, I looked at this IV to make sure that, and if I got a catheter shear, it's probably better to know about that sooner than later. It can form an embolism, and if it gets through the heart, again, it can cause some serious problems. Every now and then, you're starting an IV, or you think that it's in a vein when you're actually in an artery. In critical care medicine, we call that arterial line. And normally we would put a transducer on it. It's a wonderful thing. But again, if you are starting an IV and it is bright red blood that's coming out and is pulsing up through the IV, congratulations, you started not in a vein, but in an artery, and you're probably going to need to discontinue this. And if you do inadvertently do this, you're probably going to need to hold that for about 15 minutes, okay, to stop the arterial bleeding. Last but not least is you can cause circulatory overload if you give somebody too much fluids, all right? It can happen. It is not a good thing. The good news is most humans walk around about a liter down. The bad news is that, if the patient's already fluid overloaded and then you give them more. This leads into a really, I'm more of I'd prefer you flow the fluids than to restrict them. But again, reassessing every 250 is a great way. Listen to their lungs. If they are complaining of they're having trouble breathing and you start hearing crackles, it's probably time to stop any type of fluid bolus that you're giving the patient. Flambophilitis, again, that's where you've got a clot formation, and it starts to irritate the lining of the wall. That's that Flambophilitis again. And then when you leave the catheter in there, by the way, it continues to create more irritations. Yes, if you let air go into your IV, it can form an air embolism, and that's my understanding is a pretty painful way to die. If you leave the IV in for too long, usually that's why we change them out every 3 days in the hospital. Usually they'll change a field one in every 24 hours, but it can necrose the tissue. Again, our IVs that we have are not meant for long-term use. If they're going to have a long-term use, they probably get a central line or a PICC line. And again, anticoagulants can cause problems. We usually use an anticoagulant to help keep the vein open. Heparin is kind of our big one that we would use to keep the vein open. All right, so if you need to change the bottle, by the way, again, new IV solution. Remember, we're going to work on that stuff in the lab, so I don't want to go into it too much. That's a lot better one to show you and not just sit here and talk about it on a set of slides. All right, we're going to hold up right here because the next is starting to talk about the medication administration, and we'll go into that further on the next video. So I'll see you guys then.